welcome to the afternoon session, and I hope you all had a good lunch. My name is Pushpinder Mangat. I'm the Medical Director of the GMC, and I'm here to facilitate this fireside chat, and that's why I've taken my tie off. So if anyone else feels like doing that, please feel free. Why am I here? I was originally going to be in one of the other seats, but due to a number of significant and, I think, positive substitutions, I've ended up here. So we're going to have this fireside chat with four fantastic victims. Oh, did I say victims? Four fantastic colleagues to answer some of the questions that you've been putting to us via the online system. Just to remind everybody of the themes of this conference, there's 5 themes, and I think our questions will cover the majority of them. So patient needs, service requirements and training, are they all the same? How employment practices can enhance well-being, retention and training. Supporting every doctor and dentist to be the best they can. And how we encourage career development in all grades of doctor and dentist. And finally, developing leadership in medical education. So you're all like a selected, positively selected audience where the last one will be something that you would support. I'm now going to turn to my colleagues who I know pretty well from my previous roles to introduce themselves and they can tell us why they're here. Can I start with you, Sir Michael?
Somebody else manages my diary. No, I have to say, delighted to be here today. Education has certainly always been something that's very close to my heart. I was a postgraduate clinical tutor. I was a medical director in a trust. I was fascinated to listen to Derek Galen take us down a trip down memory lane. I remember Derek being appointed into post, all of the changes through medical education over the years. I think it's actually fundamental to patient care. I think it's going through an interesting time as we transition. I was fascinated to hear some of the presentations this morning about some of the real opportunities, but I also wanted to be here to say thank you to each and every one of you for all that you do and all that you continue to do. I'm here today as a product of the medical educators that I had the privilege of experiencing their mentorship, their support, and their development over many, many years. And there will be individuals whose lives you're touching, their professional career, supporting them through some personal challenges. And I just want to say a huge thank you. So thank you very much indeed.
Thank you, Michael. Shona?
So I'm Shona MacLeod. I'm the Director of Education and Training in NHS England. And I'm here because I know I need to continue to learn. I enjoy developing. I like to refresh my thinking. I like to hear new ideas, successful old ideas, have initiatives. I like to hear what others think, and I find the networking, the conversations really allow me to expand my thinking, test out, hear what people's concerns are, what solutions they think there are to the big problems, their ideas, examples of innovation. And I don't think I'm the only one, which is why Namita and I work to bring this together, because you're all really good at supporting others, but you also need the headspace and the time to think and develop yourselves.
Thank you, Shona. Emma?
Oh, thanks, Push. I'm Emma Watson, and I'm the Medical Director for NHS Education for Scotland. And like Shona, I'm here because I want to learn. I want to be prompted to think differently. But really importantly for me, I want to use this venue to really tune in to what my colleagues who are on the kind of clinical floor educators, what would make a difference for them? What solutions are they coming up with? Because actually if we invest and support our educators, they will help us navigate the complicated solutions that will make things better for our resident doctors in training, our locally employed doctors, our SAS doctors, and more importantly, for our patients and the communities we serve.
Thanks. Thanks, Emma. Tom?
Good afternoon, everybody. I'm Tom Lawson. I'm Medical Director for Health, Education and Improvement Wales. And I too am delighted to be here. Slightly unexpected timing this afternoon, but the purpose for coming is DMEC is a fantastic opportunity, isn't it? Having so many like-minded people to share and learn with. Great contingent from Wales coming up, and as I came up on the train, my role was here as a delegate to watch and support them all. But as of mid-morning, when my chief exec phoned to say she had food poisoning, unfortunately, I found myself sitting on the stage this afternoon. Which is why I am the one that's dressed most like ready for a fireside chat.
Come on, Tom, that's how you normally dress, isn't it? Okay, so we've had a whole load of questions from you, which is good, and we've tried to put them into some themes. There's been quite a lot of questions about uncertainty with the incorporation of NHSE, which is only England focused, of course, into the Department of Health. So some people have got concerns about how that's going to impact the education function, Shona, and I was wondering if I could come to you on that.
So the question was, how do we reassure and motivate educators concerned about their job security? Now, I think all around the country there are educators concerned about how that will work as a career, whether they'll have the time, whether they will get time in job plans, whether they'll be supported. The difference we have in England at the minute is we have NHS England, which has already incorporated Health Education England, moving into what will be a new Department of State. And we hear lots of rhetoric about the need to save money and the need to reduce on jobs. So it is a very uncertain time for people being connected to that organisation. But we do also hear how important it is that we have a workforce for the future. We have a plan, and we are having a 10-year workforce plan. And everybody knows you cannot develop a workforce and hope that they just absorb the learning they need if you put them in an environment with no support. And so whatever organisational form we have in the future, there will always be a need for people like you to educate, to motivate, to support people who are learning. So exactly what organisation we will be in, what the jobs will look like, is uncertain, and I'm sorry that you're all having to go through that. But there will be a need for educators. There'll be a need for medical, dental, healthcare professional educators in the future. So there is security in you have chosen something that is necessary. And in the current VUCA, volatile, uncertain, complex, I wish I hadn't said this now because I have to remember all four, ambiguous environment that we all work in, perhaps that will be the way of the future. But as long as we will need healthcare, we will need people to deliver it, and we will need people to develop the next generation. So I'm sure over the next year there will be much greater certainty for all of you. And so for all the people who've asked that and are feeling the discomfort of uncertainty, I'm sorry, and we will try and get you reassurance as soon as we can.
Thanks, Shona. There's a bit of organisational change in Scotland as well, isn't there, Emma? Is there anything you would like to talk to us about that?
So for those of you not in the Scottish context, NHS Education for Scotland is coming together with another national board, National Services Scotland, to form a new entity which will be called NHS Delivery. And actually we're seeing this as quite an exciting time. One of the key objectives of this new organisation is going to be to ensure that we train the workforce for the future. So I think for educators, this is quite an exciting time. I think there's going to be real opportunity for us to describe what the infrastructure needs to be rather than what we've currently got, some of which is good and some of which is under strain. I was really struck, though, this morning listening to Jim when he described what we do as a £300 billion industry. And actually, if we reframe some of the challenges, some of the pressures that we're experiencing, and actually do what all of you do best, which is look out and future focused, because there's nothing else that you can do when actually you're nurturing the workforce of the future. I think it could be quite exciting.
Thanks, Emma. I'm going to move on, unless... Did you want to say something, Tom?
Oh, I can do,
Yeah,
push.
go on then.
Yeah, I mean, there are times of great uncertainty, aren't they? We're lucky in Wales at the moment that we don't have a restructure planned, but I think the educators are absolutely pivotal to the delivery of medical education. So for us, I think it's not so much about the sort of security of their jobs, it's how we retain people amongst the current pressures when we see that burnout rates amongst trainers are consistently higher than they are in non-training posts. So there are a lot of initiatives underway, and certainly we ensure that the trainers and the capacity of trainers to support training is fully considered in any initiatives that expand, because there's only so much that people can do. So supporting educators at times of uncertainty and throughout normal times, if they exist anymore, is pivotal.
Thanks, Tom. Michael?
Yeah, I was just going to pick up on some of those comments. I think that change is always challenging, and certainly the insecurity that comes with that is unwelcome. And I think certainly it's always frustrating where perhaps there's a view that it's change for change's sake as opposed to change for necessarily a particular reason. And that's a general point that I'm making as opposed to any specific point. But what I would say is that at times like this, it's really, really important to stay focused on what you do and what you do well, and actually use as an opportunity to shape and influence and inform. I think that's the crucial message that I would want to convey. You have contacts, you have networks, use those to best effect, because with every change comes an opportunity. I suppose I've always been someone who likes to see opportunities for change, because there is a momentum sometimes about influencing things for the better, and I think that's perhaps the way I would encourage you to look at it. But I do accept that it can be very, very unsettling, and I'm sorry that many of you are experiencing this at this time.
Thanks, Michael. I mean, the thought that comes into my head over this is HEIW, NES, what was HEE, and NIMTA are all statutory education bodies, so there has to be a statutory function for education. So whatever comes out of the restructures has to, because it's statutory, has to have that function in it, because otherwise, people like myself in the GMC and each other can't contact each other to share our experiences and work together well. So I think something has to be there, which is a really important point to make. So the next one, I'm going to come to Emma on this, is that should we be establishing a standard 40-hour work week for resident doctors, given that many are now opting out of full-time work, sometimes only 80% or even less full-time equivalent?
Push, that's a great question. I don't know who asked that, but actually I think it's really important that we do start looking at what it is we're asking our resident doctors in training to do, and then what is it that we absolutely need them to do in terms of their own personal growth, development, becoming that GP or specialist or SAS doctor or locally employed doctor that they want to be. And what is the service that we need, and how do we remove potentially low volume, low priority, low need tasks that maybe nobody should be doing? In terms of the 40-hour week, when I'm thinking about that in the Scottish context, our new Agenda for Change contracts are moving to 36 hours. So what does that mean when we've got resident doctors in training working 48 hours and as we all know, sometimes in excess of that. I'm also really thoughtful about how our more senior doctors are working into the future, and actually fewer of those want to work 48, 44, 40 hours a week. And when we think about the longevity of a medical career, I think there's something really important for us to look at in that space. And I think we should be socialising those concepts, and what can we do to change how we work to make that reduction possible.
Yeah, thanks. Tom, any additional comments on that?
Yeah, I mean, it's a fascinating area to see the changes that have happened in recent years. And I think it's really important that we embrace it. We're so slow to change. We're all facing the same challenges across the 4 nations, but in a slightly different context. We're just, our resident doctors in Wales are just voting. Currently is out to ballot on a new contract, which does change and address a lot of these things in terms of working weeks. Because of course, although we've seen an increase in this 80%, resident doctors working 80% a week, it's not exactly part-time for most working people, is it? They're still doing more hours than the normal working week. And this isn't going to change, and nor should it. And we've had 4 resident doctors giving their own story recently to us in Wales about the context and the reason they're working less than full-time. One of which was through personal circumstances and would not have continued training if hadn't been enabled to. Another one was to develop other portfolio aspects. So there's so many opportunities here, and we simply as a system need to get better planning that is the way it should be, and it's going to bring so many advantages. It's just the challenges of implementing it at times of such pressures and services, and we've been slow to realise it. We still plan rotas, don't we, as if there's 100% post availability, and all of these things need to change. So I'm pleased to say that, certainly in Wales and with the leads from some of our leads in HEIW, we're working across our health board providers to start to look at mechanisms that plan for this. We're certainly hoping our new contract gets voted through by resident doctors, because obviously the challenges across the border in England are highly visible, and are obviously never too far away if we don't improve working conditions generally. And this is a really, really important thing to improve. We haven't done it well enough. We haven't kept up with the pace of change, and that is something we need to do better.
Thanks, Tom. Anybody else want to?
Yeah, I mean, I agree entirely with Tom's point. I mean, I don't think we've kept up with the pace of change, and indeed the complexity and the intensity of work now compared to many years ago when I was a junior doctor or a doctor in training. So the intensity of the work is different, and it's quite clear that resident doctors coming through, that want a different work-life balance, and quite correctly so and rightly so. And I do think that we need to ensure greater flexibility, more responsiveness. I think we need to do much more in terms of making our medical workforce feeling valued, and that includes educational and training opportunities as well as everything else. I have a daughter who's an F1, I have a daughter who's an ST6 in anaesthetics. We had Sunday lunch yesterday, so I get it in the ear every Sunday. So there is more that we can do. I think things have improved, but not enough and not quickly enough. And we do need to adapt to the changing expectations and the changing expectations of the medical workforce.
Yeah, people of my age cohort need to stop thinking about what it used to be like in our days, because it was very different.
It was.
And what's expected these days of doctors in training and the pressures on them are very, very different to when I was at that stage. And I think it's really something that needs to be recognised. Lots of excess hours don't actually get you anywhere. You end up with even more burnout towards the end of careers. And people who work less than full-time these days, I think they'll have a bit more longevity in their careers, which I think is of benefit in the future.
You've just nicked the point I was going to say.
Oh, sorry.
No, I do think it is we want people to be working in the NHS for a long time. So we have to listen to all the ideas that would help us retain
Yeah.
them.
Sorry, you shouldn't.
It's okay, Push.
Okay, there's been a lot of questions about locally employed doctors and SAS doctors in relation to their educational opportunities and in relation to their increased numbers. I mean, the number of locally employed doctors in the UK has gone up to 37% of the total working group of doctors, which is the highest it's ever been. Only, I think it was 7 or 8 years ago, it was sitting around 15%. So they're almost a new cohort of doctors that we need to look after. I was just wondering how we come to you, Tom, on what can we do and what are we doing to try and help LED and SAS doctors?
Thanks, Push. I think there are a number of different categories in there, aren't there? We
Yeah,
talk about
absolutely.
locally employed doctors, but of course within that group there's a lot of variations for reasons why people are locally employed doctors. There's post availabilities, accessing training posts. There's others that choose it for a particular location or a specialty. And then there's SAS doctors. And in Wales, we're particularly focused on both of these groups. Colleagues probably are aware that if you look across the UK, about 30 to 40% of our entire medical workforce is made up of resident doctors. We're slightly at the lower end of that in Wales because we have a higher proportion of SAS doctors, always have, and like the other nations, the percentage of locally employed doctors is going up for the reasons I just outlined. So it's incredibly important. I think the distinction between training and non-training posts has blurred. There are far more opportunities now for locally employed doctors to gain evidence of their competencies within those posts and then count those towards their training in subsequent career choices. But it is really important. There is definitely, in my view, still a difference in terms of that educator input. I don't think locally employed doctors do get the same level of trainer educational supervision and input that training doctors do. And that is something that we're keen to focus on in Wales. And also that flexibility of pathways. So an example would be in one of our sort of rural health board areas in southwest Wales. I think everybody here is probably familiar with some of the challenges of getting internal medicine posts at the moment, which is one of those programs that's seeing quite a bit of challenge. So there we have been working with that local health board to enable a number of people who are in locally employed doctors to demonstrate equivalence in their competencies and their opportunities so that actually they'll be in a good position to apply to higher training with an equivalence route rather than and that is something that they've really appreciated. Our SAS doctors, we have a well-established network, so we have an associate dean for SAS who oversees a network of SAS tutors across all of our provider health boards in Wales, and they're responsible both for support and education for SAS doctors, and HEIW as the statutory education body funds those roles. They also have their own study leave allowance and a central educational opportunity and access to those educational offers that we give to our resident doctors. But even there's a difference in uptake amongst this group because people have different motives about what their needs and ambitions are. And we have to recognize that variability. Resident doctors through training programs, clearly that's a little bit more structured by curricula that are written by colleges and approved by the GMC, whereas there's more flexibility within those other roles. So it is a priority area for us. It is one that we are continuing to support. We provide central support for CSER pathway advice for those individuals who are choosing to continue their career through a non-training grade route. So there's a lot of things that can be done, and I think it's important we embed those.
Thanks, Tom. I'm going to come to Shona next, so nobody nicks her any points that she wants to make.
So the main, I think, aim in England at the minute is to try and support all doctors to progress. Building on what Tom was saying, there are some people who are in these roles through choice, and we have to recognise that and think about how best to support them. And then there are other people who it makes sense to do this job for a while. And there are people where they've not got into training pros, which is a different question. But everybody needs to be supported to learn. Nobody gets job satisfaction, retention, gives of their best to patients if they feel they're not valued and not being supported to develop. So one of the things is, how do we make sure that educators have the time to be able to support a much wider pool than we have been doing effectively? And that's the thinking we're having to do in England. Do educators all have time for the work that they do at the minute is a question. I'm not going to put the lights up and ask the audience, but I'm sure you all have a view on that. And it's, how do we make sure that time for education is protected for everyone, so that all healthcare people, whatever jobs they're in, are enabled to learn and be supported to learn. And as Tom's described, and as you were saying, Push, this is a group we haven't focused on enough. And now we have a real drive, led by our National Dean, Gita Menon. We've got the SEED Award for SAS doctors. We've initiatives for taking forward more support for locally employed doctors. So all I can say at the minute is, I think we need to recognise we need to do something, but there are at least lots of plans about how we would do that.
Thanks. Michael?
Yeah, I mean, I think Tom and Shona summed it up really well. I mean, I think it's about equivalence of opportunity, whether that's in terms of education, whether it's in terms of career development, whether it's in terms of training, notwithstanding that elephant in the room in terms of whether there's sufficient capacity to provide the relevant training, support and mentoring. We do in Northern Ireland Limited, I do have a associate dean for SAS doctors annual conference and events, which I go to and have been to a number of, and they're excellent educational opportunities. But I think it's actually about doing much more to recognise the contribution that SAS doctors provide. I do think our trusts have more to do in this space. It's a bit patchy in Northern Ireland. Some trusts do it extremely well, others less so. And we had an event recently. The Royal College of Physicians were over on a visit, and some very salient points were made by our SAS doctors in terms of there needing to be a better career path for those doctors to develop specialist skills to take on additional roles. So I think it is about equivalence of opportunity, I think, as other speakers have said. Thanks, Michael.
Yeah, so such a really critical part of our workforce, and like Tom and Shona, I'm really proud of the work that Lamikson delivers in Scotland, supporting our SAS doctors, but not just supporting them, having a network of SAS advisors out in the health boards and supporting their colleagues. And again, that investment in opportunity, Michael referred to that equivalence of opportunity, but not just in picking up technical skills to help a service develop, but actually broadening the skills into leadership, whether that be clinical leadership or service leadership or educational leadership. And I think one of the really important ways that will make a difference in this space is having a tranche of medical education leaders who are SAS doctors. And I think that has got to be something that we all have to grasp the nettle of.
Yeah, thanks. I mean, the one thing I can say from the GMC point of view, although I'm not a panellist here, is that there is a future education programme being developed which is specifically looking at how to support locally employed doctors in the future. And it was recognised in the medical training review in England. No surprises in it. And we're hoping that it will not only get embedded into the 10-year workforce plan that was talked about this morning, but also the examples that might happen as a result of that can be developed on a four-nation level. But there's good examples in all four countries at the moment of how we're doing that. So I don't think we're starting from scratch. I think we've got a lot of work and good examples to already look at. So I think there's exciting times, I think, and it's an opportunity as much as anything else. Okay, I'm going to move on to quite a wide subject on inequalities, and inequalities have come up in your questions based on inequalities of care, inequalities of access for training, inequalities in recruitment, and I just thought I'd I mean, a lot of it overlaps with policy areas which aren't in any of our remits, but sit with governments. But with that, I'm going to turn to Michael to kick us off on that as the only government representative directly.
Well, thanks for that hospital pass push. I shall remember that. Yeah, I think it's, I mean, there are a number of themes here, and I think it's a really important question. I mean, I think it's one thing that if we look at what we're trying to do from a policy perspective across all of the jurisdictions in terms of reducing health inequalities in outcome, reducing inequities in access, we have made some progress, but again, as you all know, and you'll know the statistics as well as I do, that we have plateaued in terms of life expectancy, health life expectancy, and in many respects that has stalled, and that is concerning. Certainly from a health perspective, it's very difficult in government because we're often working to persuade other departments and influence and shape other government policies which are critically dependent, because we know it's the circumstances in which people are born, they grow, they're educated, it's those life opportunities that they attain or don't attain, those employment opportunities that actually make the difference in terms of closing that gap, improving healthy life expectancy and addressing some of the long-term conditions that we see. I do think that flipping this into through an educational lens, I think it is about having greater emphasis on perhaps some of the, when I heard Derek ask whether there was any public health doctors in the room earlier, I think it is about having a greater emphasis on some of the influence that we can bring to bear as healthcare providers, as doctors, in terms of those factors that determine healthy life expectancy. I do think that it's fundamentally about shifting the model of healthcare provision into keeping people well and addressing the factors that make them unwell. In terms of how we might do that in education, I do think that it's about looking at for instance, the admission criteria into our medical schools. It's about ensuring that we give opportunities to people from across the range of socioeconomic groups. I think it is about enhancing those opportunities, and I think it's also about equipping our undergraduates and postgraduates with an understanding of the populations that they serve, including underserved populations. I do think that there were a number of issues about inadequacy or inequality in resources, inequality in trainee placements, etc., as well. And I think we need to give some consideration as to how we use the resources that we have in a much more thoughtful way, recognizing that providing healthcare in certain parts of these islands is much more challenging than another. Now, there are differences. You know, providing healthcare in a rural area can be as challenging, although in a different way than providing it to many underserved populations in an urban area. But I do think that we need to equip our trainees with the skills and the knowledge to provide that care in a variety of settings. And Ali Carter was presenting earlier, and she put up a very nice set of slides. And she talked about, you know, compassion, and she talked about empathy, and being able to relate and to provide holistic care. And I do think that's something that we need to maintain the balance as we increasingly use AI and augmented care. We need to make sure that the personalized aspect of it, that we retain that, and that we can actually bring care and tailor care to meet the individual patient where they are in the community that they are from, and communicate our messages to them, our interaction with them in a way and in a language that they actually understand. So a wide-ranging question, and I've given you a wide-ranging answer there, Push.
I think you gave a fantastic, you took the hospital pass and kicked a drop goal, I think. There. Well done. So well done. Tom, can I see what you've got to say
I
about
think there are a couple of elements to that question. The health inequalities challenge. Still today we see this difference in outcomes for patients. Tudor Hart was a GP who many of you will be familiar with, who worked in the Avon Valley in one of the old mining valleys in South Wales, and he described that inverse care law back in the early 1970s. So those with the greatest need for healthcare get the least, and vice versa. And that's still the case. The link between wealth and health is still as tangible as it ever was. There are elements to changing that. We all hear about the left shift, the focus on local availability, prevention. These are really important, but they're not easy to align with the system needs, with the needs and the desires of individuals. We do, in Wales, we're the first nation, I think still the only nation that has built into legislation the well-being of future generations in an act that requires all our public bodies to specifically account for their actions in terms of the implications for future generations. And we've seen a number of things changed because of that, a lot of which are to do with transport and construction initiatives. We're seeing less impact on health outcomes, even with that in place, even though as part of that, health boards are obliged legally to focus on that prevention agenda. So there's still a lot more to do. In terms of the inequalities and what Michael was referring to about where people want to be to work versus where they need and trying to achieve that balance, it's really tricky. I also enjoyed the foundation session this morning and listening to Mike Masding talking about the impact of that preference-informed allocation process, which is fairer. The outcomes of it were quite startling, and that was palpable for us in Wales, whereas our Southwest Health Board that I referred to earlier, the previous year, 50% of the foundation posts in that area were vacant consistently year on year. That's a huge, these are qualified doctors, so even at foundation level, their importance in service shouldn't be underestimated. After PIA, the even distribution meant there were no vacancies. It was, and we had letters in saying what a difference that had made for patient experience, etc., etc. There was noise because people were allocated to those areas when they hadn't chosen or wanted to be there. But goodness me, the feedback that we got from them once they'd been there and experienced it was totally different. So a lot of it is about that sort of understanding of where you want to be and then the experience and making the most of it when you get there. In fact, one of the small hospitals there, 6 of our foundation doctors enjoyed it so much, they've all stayed on to work in the same hospital as locally employed doctors going through that IM training pathway that I discussed before. So it is difficult. Balancing the system needs, our responsibilities as public servants, we can't all work in the same place. When I look at the first choice geographically for foundation in Wales, 85% of the people who've put it down first choice is within a 15-mile radius of Cardiff. So if you live elsewhere in Wales, there's a little bit more of a challenge. People aren't queuing up to come and see you. But these are the things that we're trying to balance through all of these things. And it is important, because if you don't value and understand what individuals also need, then you won't get that collective drive to change things for our patients, which, remember, still has to come first for all of us, doesn't it?
Thanks, Tom. Scottish view?
Scottish view. So I think the Scottish view does really align with what we've heard so far, and the work that we're in the midst of delivering is to ensure that we've got the right clinician in the right place with the right skills to improve the outcomes for that population that they're serving. And I think much of this also will help our resident doctors in training feel more valued, because they will be able to see that direct line of sight between where they are and the impact they're having. And I think we potentially have been a little bit remiss in our conversations with our undergraduates who are our future workforce, and really having open conversations with them about what is it that they want to see, what brought them to the medical profession when they have so many other things they could choose. And then how do we hook into that? Because the medical students I meet really want to make a difference. They really want to be facilitated, to be part of that change. And we somehow miss that. We miss that hook. And we potentially drive them away from the space that they came from. And building on Michael's comments, what we know, the evidence base is that if your caregiver or your healthcare provider looks like you, sounds like you, understands what you mean when you use a certain phraseology. I suppose Jim was teaching us how to decode politics earlier, but actually that same language barrier where we're saying the same words to mean different things in different communities really gets in the way of accessing healthcare, and such that people are scared, they stay away and they don't come forward. So for me, it's about having a future workforce who notice who isn't coming forward, who seeks out those who are not in the clinic, not coming to general practice, not seeking out those screening methods. So I think we need to do much more in this space.
Yeah, thanks, Emma.
So we have a lot of the distribution is based on historical events, chance. The distribution, if you were going to put down where you would put your medical workforce, where you would educate them, train them, wouldn't be where they are on the map at the minute. And where would we put them if doctors who are going through their early training could choose? Or where would you put them as medical students? And if this doesn't align, then what are we going to do about it? And that's very much the live questions for the 10-year workforce plan. Because we can't have doctors, as some of the questions referenced, worrying that they will be unemployed. We can't have areas of the country where there are doctors who are not in jobs. We can't have it where the country looks as if it doesn't welcome IMGs. But how do we balance that?
Really tricky.
And all of these things, we have to look back to what are we here for? We're here to spend the taxpayer money to make sure they have equitable health around the country. And then how are we trying to do that? And we're trying to do that in a way that gives the doctors a good work experience so they can be the best they can be and provide the best care to patients. And it's difficult to balance it, but that's the conversation that we are now having. And it's good that we're having it now, even if historically we've ended up where we are, having not had it.
Yeah, yeah. Wow, that was a tough question to be trying to answer. We've got 6 and a bit minutes left. I'm going to just ask, there's one question that's been coming through repeatedly about educators. And a lot about burnout in educators. Is there anything we can specifically do on that? Is there any thoughts on that Shona, if you could
I
kick
think
off on that?
one of the interesting things with people who worked really hard on helping us recover from COVID, when you ran sessions on burnout in educators, nobody wanted to come. But when you ran an educational session for educators and how to stop burnout and the impact of COVID on their learners, loads of people came, which shows that as a community, you're really good at doing things for your learners and not awfully good at doing it for yourselves. So I think there is a challenge for us in how we support educators to look at how they balance their lives, how we try and make sure there is time in the job plans, which is work Stella Vig is doing, but also how we try and make you able to attend events like this, to take time out and think.
Yeah.
But it is, as a community, you're really good at looking after other people, and it's a challenge to us to make sure that we help people look after themselves.
And one of the big things that Michael West says is being empathetic and compassionate. But he also says you need to have the headroom to deliver
To be
that, which
empathetic
is
and compassionate.
what we're talking about with them. Emma, any thoughts on?
Yeah, so I think for me, with the educator workforce, as Shona has highlighted, we've got a group of colleagues who will always go above and beyond. And they will put the needs of the patient and then the needs of the learner, and they forget about the needs of themselves. So it's really incumbent on us in the medical leadership roles to ensure that they have the genuine infrastructure for support, that we give them permission to take the time to do the tasks that help them, that give them the space. Because I think we can, all of us in that very pressured work environment, forget that sometimes we need to say it's okay for you to take that time away. I'm not expecting you to be working into the evening, robbing time from your children and families. And so I think we need to look at quantifying the resource for the learners that we have in the system. And then how do we do our best to honour that for the educators? But also, how do we take away from the educators the tasks that, again, of no added value, that are the habit of our system, that creep back in? Yeah. We were pretty good in COVID days of removing some of those. But they're all back, and they've all got a rationale for being back, and I think we need to be challenging ourselves.
Thanks, Emma. Tom?
Yeah, I mean, educators are that group of people who will go the extra mile, always. And the stats are clear from the GMC surveys that the rates of burnout are higher, and that is partly for that reason. People don't say no, they're there to support those resident doctors and any other healthcare professionals they're training. So they do go the extra mile. We have to get better collectively about not adding to that, because people who go that extra mile, generally speaking, take on more and more, and even things, large increases in trainee numbers without thinking about the impact on educators. You can't just do it one way. So I think it really is important. I think it's also time to start looking at all the processes we expect our trainers to do. It seems a bit crazy to me that we have 3 senior trainers looking at a portfolio at ARCPs to decide if checklists and things have been met this day. There must be a quicker, more efficient way to look at how these things are recorded without using time. So, for our educators, we want to make sure that they have the time to train, they have the time to train and develop themselves. And a bit like anything, you want people to work at the top of their license, to use that expression. We don't want people doing things that they don't need to do. If we can get AI and to do some of the processes and things like that before, but just like clinical medicine, we have to look at technology and supporting our trainers in what they do.
Thanks, Tom. We've got just under 2 minutes left, Michael.
Yeah, we'll speak
Last
quickly.
word with you.
Speak very quickly. I think doctors generally are not very good at looking after us. We're not good at looking after ourselves, full stop. I think that educators are a self-selected group who are probably at one end of the spectrum in terms of compassion, caring, and going that extra mile, because you're focused on giving back to someone and giving them the opportunity to be as good, if not better than you. And very driven in that space. And with that, I think comes, as Tom has said, the downside of that, which is you will undoubtedly push yourselves hard. You will take on more than you're able to do. I think we need to do more, such as events like this, in communicating to you how much we value you. You need to see that the role and your contribution is valued. There does need to be more that we give thought to in terms of how we best support you, and I'm sure you have views on that. And also how we take away, as Emma has said, some of the burden, some of the bureaucracy, some of the nonsense that you find frustrating. I think that will undoubtedly greatly assist.
That's brilliant, thanks. So with 20 seconds left, I think I'm just going to bring this to a close. First of all, I think it's been a really thought-provoking session. And it's really good to hear that there's so many things going on in all all 4 nations. And in my role, I'll be meeting everybody on the panel on many occasions to discuss some of these things again. But I'd just like you to perhaps thank everybody in the normal way for the contribution. And just a reminder that you've now got less than 10 minutes to get to your next breakout session. So any rush, don't rush over each other on the stampede. So thanks very much, everybody. Thank you.